The title of this talk this morning, as you've seen already, is I've just called it Neuroplastic Brain, Neuroplastic Pain, Understanding and Healing Chronic Pain using the mind-body connection. And as I alluded to, this has been an area of mind-body medicine. I've had a very long-standing interest in mind-body medicine since even quite a bit before deciding to go to medical school, and it's been a really important part of learning and clinical practice for a very long time. But it was kind of more recently that I encountered the work of Dr. Howard Schubiner in particular, and the kind of the path that has led me on since then, kind of more deeply delving into certain areas of this field of mind-body medicine, especially around the treatment of chronic pain, has just been an amazing journey and process. Just exciting because I've been learning so much, and exciting because as I've been implementing in my practice, just what it's kind of facilitated in that has just been just a wonderful experience all around, and continuing to learn and grow. So just first off, just have to express gratitude to all of my teachers in this process and the training courses I've taken. Dr. Howard Schubiner is probably my principal teacher in this, I would say, but I learned from many others, amazing clinicians, researchers, and teachers in this process, including some I've just more read their work and their papers and seen some of their presentations, and I'll be doing my best to integrate some of that in a way that hopefully will be interesting, helpful, and engaging for everybody this morning. So I just want to kind of note that gratitude to the teachers who have come before me in this process and who I continue to learn from. So just want to start with that note. Before we dive in, I'd like us just to all just take a moment. This is something I think that we, in a great way, allow ourselves to do more in this form in Integrative Health Grand Rounds. But with regard to this topic, I think it's really pertinent again, because if we allow ourselves to just kind of take a minute and cultivate that sense of mindful awareness, wherever you are, sitting, standing, walking, close your eyes if you feel most comfortable with that. Just take a moment to just tune in. Just be aware of sounds, sensations around you, sensations, experience within you. Just allowing yourself a moment to be fully in the present, right here, right now. And acknowledging that when you allow yourself to do this, as we've learned through research, this is one of the most powerful ways that we can cultivate ourselves, the power of neuroplasticity, this open, non-judgmental awareness, and opening up the greatest possible potential for learning and growth in all the ways that you might not even know possible. Just taking a deep breath in through the nose, out through the mouth, and then allowing yourself to come back to the virtual room. Open your eyes if they're closed. And just check in, just notice how that feels. And we're going to come back to some of the science of what we just did in a moment. Something I think a lot of people know a lot about, probably in this group, but something I'm definitely going to try to integrate into what we talk about. So jumping in, I have a lot to talk about. I'll do my best to cover it well with you all. Oh, it's not letting me click. There we go. So I have no disclosures, nothing exciting there. Brief overview of the talk. is kind of two parts. First is really taking some time to delve into the current neuroscience of pain, kind of bringing our understanding of pain up to date, using what we know through neuroscience. I'm not a neuroscientist myself. There might be some in the audience, and if there are people that know more about this, and I do say something that's incorrect, please raise your hand and help me correct. Although it's kind of hard for me to see that on my window here. But please chime in. I'm not an expert in neuroscience, but I think it's fascinating and it's really relevant to what we're going to talk about. So I'm going to do my best with that. And then the next part is, that clinical part. What do we do with that neuroscience and where might it lead us in our practice going forward? So something Greta already mentioned, and we don't have to spend a lot of time on this because this is something that we're all too well aware of already, and that chronic pain is an enormous problem and challenge for us. It's actually the #1 leading cause of disability and disease burden worldwide, and more Americans have chronic pain diagnosis than heart disease, diabetes, and cancer combined. And whenever I see that data, it's just, I think a really kind of significant kind of number to try to grapple with. So, we've just struggled with it thus far, and unfortunately, we're still struggling with some of the consequences of the opioid epidemic, and so it's just can be a really challenging topic. Sometimes it contributed to burnout when we don't feel like we have effective options to treat chronic pain, when we really want to help our patients any way that we possibly can, which is really why we're doing this work. So to kind of take a step back, I like to come back to this really basic framework to think about what are those basic components foundational to healing, I think, in any situation. First, we need to have the right diagnosis, the best understanding we can of that, and its root causes. The treatments, of course, very important. We need those. Hopefully they're based on the understanding of the diagnosis, the best that we can. Other parts sometimes we don't talk about enough, but I think in integrative health, we need to give more attention to, which is how important the human element is, that therapeutic relationship between patient and clinician, for example, and the other ingredient of hope, that there's light at the end of the tunnel, that there's something that is going to help me, and there's that crucial ingredient. There's a lot of cool research done on this, including some from our own department, probably people in the audience here who are involved in some of that, and wish we could spend more time on that, but we don't have time, but it's so crucial. So that first part, understanding and explaining what we're talking about. This question, what is pain? It's a part of our lives every single day, but we don't always take the time to really deeply think about that question, and sometimes we don't want to because, pain isn't necessarily a pleasant topic. But if we look at it more closely, there are 3 concepts that I like to use to help us understand that better this morning. I've broken it down this way. Number 1, this idea that pain is in the brain. That's where pain occurs, and pain is not the same as nociception. Nociception, the technical term for the sort of process whereby noxious stimuli stimulate peripheral nerves and send signals to the central nervous system. Those 2 things are not interchangeable and equivalent, and I think that's a really important distinction for us to make. Talk about that more. Other is that the brain is a network. We'll talk about that in detail, well, in some detail. And predictive processing or predictive coding. It's called more predictive coding in the literature. I like maybe the term predictive processing of the brain. So maybe a little more layman's term for more people, I think, potentially. So that first part, pain is in the brain, and it's not the same as nociception. So what do I mean by this? This is our sort of old model of pain. And I think the model that most of us sort of intuitively gravitate towards when we feel pain, think of pain, see patients with pain, that pain is this really straightforward linear process where, maybe you put your foot too close to the fire or touch a hot stove, and the nerves send the signals up to the brain, and the brain is just sort of like chilling out, waiting for those signals. And then it generates the experience of pain, kind of passively and just objectively reading out what the body is sensing. We kind of tend to sort of assume that still to this day, even though we have some kind of updated pieces that we've accumulated over time. This is a diagram from a paper published not that long ago in 2010 that I'll talk about in a second. Doesn't tell the whole picture. This is not that different really. It's pretty linear. Injury communicates via maybe different types of nerve fibers. They synapse in the spinal cord. They go up to the brain. Maybe there's some descending modification from certain brain regions, at the spinal cord level, etc., to modify that experience. So the brain might be somewhat involved, but still, as you can see in this diagram, the brain is, not necessarily the primary part. But it doesn't take a lot of imagination to kind of think of a couple of examples where this kind of linear understanding just doesn't hold up. This is a picture of someone who, as you can see, is missing part of their right lower leg. They had it amputated. And a lot of people have heard about this phenomenon in some way, this idea of phantom limb pain, where people literally do not have that physical body part anymore. And yet they have potentially excruciating, vivid, severe experiences of pain that they're definitely not making up. And they, want to get out of more than anything because it can be very severe. And yet they physically do not have the body part. And so if you think about those older models where it's like strictly sort of this linear peripheral tissue dependent process, it doesn't make sense because they don't have that peripheral tissue, right? We'll talk about in a second more like what neuroimaging shows about what's happening in these people's brains and in people who haven't lost part of their limb, their brains. But the upshot is actually, it's actually very similar in the two cases in that it's the brain that's playing the primary role in generating and creating this experience of pain. And that's how people in this situation can unfortunately have this type of phantom limb pain. This is a little picture taken from a paper where they're using mirror therapy, and this will maybe make more sense in the context of what we'll talk later of how this actually works to change the pathways that are actually responsible for the pain, which aren't in their leg, it's in their brain. This other kind of couple examples is sometimes used with patients. There are two case reports here, two different patients. One on the left was, this is apparently in the UK, construction worker. This was in the 90s. It got published because it was, I guess, an interesting case. Construction worker fell on the site, on the job. They landed on a 7-inch nail that went straight through the bottom of their boot. And they were immediately in terrible, agonizing pain. They took them to the ER, whisked them to the ER, and they were just like screaming and like awful, awful pain. They had to give IV sedation to even be able to cut away the boot because he just could not hold still. It hurt so bad. And as you might guess, lo and behold, when they cut away the boot, the nail had gone right through two toes, or in between rather, two toes, without any tissue damage at all. You can probably guess they didn't write this in the case report, but I can guess that person breathed a huge sigh of relief and the pain level went down really quickly. The other case is kind of the opposite. Another construction worker, I don't know why they're all construction workers in these cases, but that are in the literature here. But anyways, it's a construction worker who went to his dentist and he said he noticed a toothache kind of for about the past week or so. And it was kind of bothering him a little bit. And so he said, okay, it's been 6 days. I need to go see my dentist. So the dentist does the x-ray. And then I can also imagine everybody's eyes in the clinic just like go really wide. And they find out, oh, that's not a toothache. That's something else. And they were able to figure out that the patient actually had kind of inadvertently and unknowingly shot himself with a nail gun 6 days earlier, and it go right into his skull. But again, that's not what he thought happened. So his brain didn't really pay much attention to it, and it kind of referred again to what it knew, which was the toothache. Um, so this is one we don't have time to watch, but if you just put into your YouTube, if you've not seen this video, I highly recommend it. I just think it's entertaining, and it's a great kind of like illustration of the power of the brain. If you just go to the rubber arm experiment in YouTube, you can watch that later during your lunch hour. A couple of things I just couldn't resist putting in here because I just have loved this field of research for a long time, and it's really helped us to understand pain, is placebo research. So this study actually wasn't primarily a placebo trial. It was a trial for a randomized controlled trial comparing arthroscopic meniscal debridement for patients with osteoarthritis in their knee. This was almost 20 years, more than 20 years ago. And when people looked at the study initially, when they compared 3 arms where they actually went in there and they changed the meniscus and trimmed it, etc. Another one where they opened the knee and just like flushed it out. And the third arm where they made incisions, counted off the time and sewed them up again, but they didn't actually do anything in the knee. And what you can see from the data is that, what some people concluded was that, well, look, there's no difference between surgery and placebo, so surgery doesn't work. But another way to look at this is if you actually look at the outcomes, all the patients got better. The placebo arm actually got more better. They got more benefit than any other group. And that persisted for most of the duration of the 2-year trial follow-up. At the end, they all sort of converged, but they all got better. And one way to look at this is, well, look, placebo surgery works. It really helps with pain. And if you take that, more steps further, which some really brilliant researchers have done over the years, they start learning it's the brain that's doing this and playing this crucial role in our treatments. So this is another slide to just show sort of when you look at all these studies on all these different things we typically do for osteoarthritis of the knee, we can actually kind of sort out how much is actually due to the medication versus what we call a contextual effect, which is more an updated name for the placebo effect, because placebo sort of gets a bad rap. We sort of like this associated with like sort of a nothing idea, but we learned that actually this is a very real effect where the brain and the body are doing real things to modify people's symptoms. And so actually, even with things that we sort of assume is primarily pharmacological, studies would suggest that actually when, for example, you're giving ibuprofen or even giving an injection or other treatments that we do, the main thing you're prescribing and the main ingredient isn't that medication. It's actually the brain. It's the brain's what we're going to talk about, complex process of modulating symptoms. A few years ago, when I did a presentation on this, this was sort of more the level of understanding that we were talking about, sort of this conceptual idea of what goes into that effect. Now, there's been just amazing research in this field, figuring out, wow, this is complex. The brain is really active in pain, and it's involving all these different parts and networks and releasing its own opioids, upregulating and downregulating opioids and other chemical transmitters. And it's involved in this complex interplay of experiential kind of network processing in the brain, which we're going to get to in a second, that leads to this eventual outcome of how much pain do we feel. And it's just a fascinating, I think, kind of learning that we've been able to do here. So that takes us to this next part. The brain is a network, and it's really complex and highly dynamic. Again, there's sort of this old model idea of the brain, one that's kind of continued to to be popular in a lot of places and circles, and invoked a lot when we talk about the brain. You know, earlier in the 20th century, Dr. Paul MacLean created this sort of idea that we have this, you know, basic reptilian primitive brain. On top of that is the more mammalian structures that introduce emotions and all that kind of stuff, our emotional brain. And then on top of that is this, you know, kind of evolved human part of our brain that makes us unique in the animal kingdom, and we have all these very special human qualities that live there, and it's sort of this segmented, they call it the triune or three-part brain. And over time, with more sophisticated tools, we've learned that this actually isn't accurate. We've also generally tended to, and I just want to pause to give acknowledgement to Dr. Lisa Feldman Barrett, a leading neuroscientist who's written a lot of papers and published several books that I have learned a lot from. And she talks about this sort of old model of this kind of blob brain, or this essentialist view that we have like different sections of our brain that are involved in specific functions, and we can sort of map them one-to-one in this very kind of simplistic way, like pain lives here and emotions are here, and within that anger is here and sadness is here, and then taste is here, etc. And we've learned that actually that's not the case either. The brain is kind of more like this. This is an artist's rendition from a University of Dayton article of kind of trying to understand, you know, what are the actual functional connections between brain regions, and it's much more along these lines than this. Scientists have been endeavoring to understand the complexity of this, which they're finding is more and more complex than we ever even imagined. And there's so much more that we have to learn. And I've just enjoyed learning about this so much to the degree that we do know. The brain is this very complex, multi-layered, interconnected network of brain regions that is continuously active and operating in this kind of continuous back and forth communication between seemingly disparate areas of the brain at multiple levels to generate our experience and govern our physiology. And so we're developing models that are much more like this than that previous sort of simplistic view that maybe some of us even sort of grew up with. And I know even in my training, those were still very frequently talked about. So on to pain. So how does this relate to pain specifically? This is a really interesting study that was done by Moreau and colleagues, that initially their hypothesis was they were kind of set out to try to understand, okay, so pain is happening in the brain and all these other things are happening in the brain. We can use functional MRI to look at it. Can we figure out what parts are specific to pain or nociceptive sensations? Sort of trying to think of those again. Are they equivalent? Is nociception really unique compared to other sensations? And can we kind of figure that out, separate the two? So they did this really elaborate study. This is just one diagram from their paper. And what they found interestingly, is that you can't really separate them. That the network of brain areas that respond to noxious stimuli, like someone putting, like maybe you accidentally touching the hot stove, or someone putting a hot thing on your arm or something, like they do in experiments, those are actually not pain specific, but they're also multimodal. And they're comparing it to other things like non-nociceptive somatosensory stimuli, like maybe a light touch or something like that. Auditory and visual stimuli, which we often really think is very different, right? But the brain is actually using the same networks for all of these things. And they also found that what dictated the magnitude of the response in the brain was the relative proportion of its perceived saliency of that stimulus. In other words, how important it was to the person. So their conclusion was that this pain matrix sort of network that they were investigating further at this time, 2011, actually can respond to any salient or behaviorally relevant stimulus, regardless of whether it's nociceptive in nature. So to kind of let that sink in, because it's kind of a mouthful. But so what we kind of previously thought were pain areas of the brain actually are not specific to pain and can be, like they said, based on saliency and behavioral relevance are activated. This takes us to the next study, which is another really fascinating study by Torwager's lab. Torwager and colleagues, they did this experiment where, again, using fMRI to scan people's brains, they took 40 participants who had just recently gone through an unwanted breakup of a romantic relationship, and they were feeling like really bad, like intensely rejected. So they had them do a couple of different tasks, and they kind of aligned the experimental protocol appropriately. One task was that they had to look at a headshot of their former partner as they thought about their specific rejection experience. The other task, they put, like we were saying, a hot stimulus on their arm meant to be noxious to try to create physical pain. These scans were indexed against other mental physical tasks that were sort of meant to be neutral, non-specific, positive even. And what they found really interestingly was that, as you can see here, there was significant overlap in the brain regions activated across those two tasks, including in the secondary somatosensory area, the area that's classically our previous models of the brain, associated with the physical body. So, what do you take away from this? Some people were saying, well, this shows you why social rejection hurts. This is like, how does it mean to have a broken heart? That kind of physical experience. Another way that I think is not mutually exclusive, but just another way to look at this in the context of the study we just looked at, is that what the brain might be doing here is that it's utilizing its salience detection system to process information about potential threats to that person. And what we're learning from this is actually the brain, again, doesn't do this in a physical pain-specific way. It uses shared overlapping neural circuitry, regardless of whether it's a primarily social emotional threat or harm, or it's physical in nature. And that's, I think, another way to look at it. So lastly, predictive processing. What do we mean by that? Some of you might have learned about this already. Maybe it's review, or you can help me explain it better. But I'm going to do my best here. This idea of predictive processing and coding. This is really central to our emerging understanding of chronic pain and how to treat it. We've learned a lot about how the brain works from studying, well, a lot of different brain processes and experiences. One of these is our senses, like vision. This is an example of visual predictive processing. And so this is probably one of the most robust areas of neuroscience research around prediction thus far. It's maybe easier to study in some ways. But if you look at this picture, right, I want you to pay attention. Some of you might have seen this before, but if you look at A and B, those two squares, look carefully and decide in your mind if they're the same or different shade of gray. Okay. Decide, look carefully. And if I say, if you trust me, I did not change anything between these pictures, I take away the rest of the image except for those two, what do you see now? Same or different, right? Original. Oops. So what's happening here? We're going to talk about more of this in a second, but what is happening, as we've learned, is that it's not our eyes that see, because our retina and our eyes are getting the same information in both slides, right? But we are seeing literally something different, right? And this illustrates that it's the brain that sees. In fact, it's always the brain that sees. Another example that's pretty intuitive for most folks is, think of like the last time you had a dream, right? Your eyes were closed and you might have seen really vivid things. And yet your retina were just kind of taking a break, right? So this, we've learned, is very likely how the brain processes and creates our experience with regard to pretty much every sensation that we know, and not just vision. And so what it's doing here, right, is the brain is using contextual clues to help our brain make the best guess at what the nature of those two squares is, right? It's trying to predict what it thinks is going to happen based on contextual information, even though it's actually misleading about what is actually there, quote unquote, objectively. And this is happening all the time. The brain uses context and those clues to try to make sense of things. This is something I'm sure most people have probably seen. The older woman, younger woman kind of combo picture. But if you kind of try this out again and think about what your brain's doing here, this illustrates other aspects of brain function where the brain is trying to decide what it's seeing in a predictive fashion using the conceptual sort of frameworks that it has available to it. And if you notice, at least I find it difficult to see both at exactly the same time. And that's because your brain typically doesn't put those two concepts together, and it has to use a network of the brain called the control network to switch back and forth, if you make it switch back and forth, to see one aspect of the image or the other, because typically we don't put those two together. And so our brain sort of has to use what it knows and maybe make a decision. That's why these pictures are so interesting. Here's another one, right? I ask you, do you see a duck or a rabbit? Which one do you see? And just try for yourself how that feels. So this, more in depth, again, we talk about kind of our old classical model of the brain, what it's doing with regard to the body. This idea, this older model is that we have this homeostatic system where the brain, again, is relatively more passive and it's more reacting to what's happening in the environment. It makes changes to try to get us back to a homeostatic set point. And it's just kind of doing that, you know, over and over and over again. Scientists have learned that that just doesn't match the experimental data. And even intuitively, it doesn't really fit, because if you think about it, it just wouldn't be efficient for the brain to be doing things like that. It's kind of slow, right? We learned the brain is much more complex and way more evolved and efficient than that. And so what it's doing is something that scientists have called allostasis, the dynamic process in which the brain actively anticipates the needs of the organism in order to regulate its core physiology, including endocrine, immune, and very importantly, the autonomic nervous system. And it's doing this in a feed-forward fashion, meaning the brain is generating predictions before something actually might happen to try to anticipate the needs, glucose levels, sodium levels, potassium levels, levels of all the different hormones, whether it's thyroid stimulating hormone or, different, ACTH. So it's sending all these different kind of signals out to try to predict what the body needs so that it can stay ahead of the curve, which is more efficient for survival than just reacting to things afterward. It takes in information from the outside to revise its predictions, and we're going to talk about how it does that, incorporating into its prior knowledge, and it kind of has a cycle, but it's doing it not reactively, but predictively. This is another illustration which I've adapted from Dr. Feldman Barrett's work, showing this cycle in which the brain is issuing predictions about what it thinks is going to happen, or thinks or anticipates. And that generates actually a whole host of reactions in our bodies. In our experience, that ends up causing what scientists have termed simulation, or some have said it's kind of like actually a controlled series of hallucinations in which, while we experience things moment to moment, it was actually generated and predicted by the brain a moment before. And the brain is doing this all the time, every single millisecond. And even though we feel like it's happening to us now, largely it was actually already predicted based on contextual clues and other information that the brain had to make those predictions. It can then potentially revise predictions and change our experience in a predictive fashion by taking in information from sensory input. But it doesn't necessarily have to do this. In fact, the brain can't literally do this because if it did, it would just be overwhelmed. There's just so much sensory information coming inside and out of the body that it would just take way too much blood glucose and it just couldn't do it. Dr. Fellenbarrett uses this example of the one human retina has as much information coming in like every millisecond as a fully loaded computer network. So the brain literally can't take in that much information from all these areas of the body. It has to be selective about what it pays attention to and what it uses to revise its prediction. Dr. Fellenbarrett also uses an analogy I find really helpful where she talks about the brain like a scientist. It's like issuing hypotheses and predictions about what it thinks is going to be the state of the body. And then it compares it to incoming data, but it can't compare it to all the data. So it has to pick and choose. And most of the time it ignores most of the data. So she sort of, uses this vision of or this image of like a scientist that maybe is kind of mostly deaf or isn't able to pay attention to all of that. And so it mostly goes with what it knows in favor of what we call stable predictions, rather than making big changes, which are, resource intensive and really costly to the organism. So it's more efficient to be stable in its predictions than to make a lot of changes all the time. This is just a diagram kind of showing some of that elaborate internet networking and connection with the nervous system of the body, which is carrying out a lot of these processes through the autonomic nervous system, for example. Incoming, these kind of predictions and the incoming sensory information. This is a couple of diagrams from a paper from Ted Kapczyk and colleagues that was actually integrating some of this theory of predictive processing and predictive coding with placebo science, the research on the placebo analgesia effect. And so this is one way to look at it that might be helpful, where if you think of kind of predictions as this kind of set of probabilities that the brain is churning out this whole distribution of potential simulated outcomes that it's trying to decide what to use. If you have something like pain and you have the brain making predictions and sensory information, nociceptive input coming from the outside, how does that kind of add up? So this is just a visual way to look at it. In this first case, the brain doesn't have much of a prediction. That's in yellow. It just sort of says, well, maybe the pain could be a lot, it could be a little. I don't have a strong opinion. It doesn't really weight any one prediction with a very high probability. Then the sensory information is there, and the brain perhaps decides to pay attention to it. Again, the brain sort of has to decide to pay attention and integrate it. Otherwise, it might just ignore that blue curve, that bottom-up signal, potentially, mostly, or entirely even. And then those are summated to kind of create this pain perception in green, which is then what we tend to experience. Again, it's not intuitive, but it's actually happening predictively. If you have a stronger opinion from the brain, then you have perhaps a bigger, more kind of narrow yellow curve, top-down prediction that then interacts with this bottom-up prediction. And you can see how in the first example, maybe this bottom-up signal and pain perception ended up being pretty close, but here they're quite a bit different. And you can play with these curves and kind of get a sense of what's different in different situations might lead to a different pain experience. And again, in a lot of ways, like we were saying, that blue curve can be rather optional and that the brain doesn't need to even pay much attention to it. Whew. So, so if we, put it all together, what does it tell us? Oops, gotta click, there you go. So towards a modern definition of what pain is, just to kind of go over this briefly, to put it all together, all all pain is 100% real. There's no such distinction as fake pain versus real pain. All pain occurs in the brain. The brain is always involved in pain. And in many respects, the body is actually optional. It often plays a relatively small role. Pain is essentially a signal that our brain uses to indicate potential threats to the body's integrity. And pain may be generated by the brain in response to tissue damage, but it can occur without any tissue damage being present. Pain is essentially, another way to look at it, is the brain's interpretation of what might be going on in the body based on sensory inputs, contextual clues, prior experiences. I don't want to spend too much time on this, but just to say that pain is, like we were saying, constructed and predicted by the brain through a dynamic process involving learned neural circuits. And these overlap with neural circuits involved in the construction and processing of emotions, reward behavior, and meaning. They're dynamic and constantly changing, meaning that they are neuroplastic. And so by definition, they can be rewired by learning and experience. The IASP has come out with an updated definition of pain that maybe more succinctly summarizes that, or key points, to say that what is pain? Pain, at our current best understanding, is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. And like they were saying in the keynotes, when we talked about pain and nociception are different phenomena. They need to be separated, and pain can't be inferred solely from sensory neuron activity. And it's this complex process that's influenced by a lot of different factors. So all this, I think to me, every time I read the updated research in these areas, reinforces like this idea that reinforces the kind of the realization that mind and body are not separate, and they were never separate. It's an artificial distinction that we tried to create in Western science, but it just doesn't reflect reality, and we really should be thinking about this integrated system as an interconnected whole 100% of the time. So how do we use this to treat patients and to help people get better? What's the roadmap to recovery, and how can we utilize this information? This is a really exciting part, of course, is the work that we do and want to do for our patients. So again, what are those foundational components for healing? Diagnosis, treatment, therapeutic relationship, and hope. So that first step, we need to establish and explain the diagnosis accurately and correctly. So there's a step-by-step process, which we'll walk through here. Not in a lot of detail because we don't have a lot of time. It actually deserves its whole other presentation to kind of talk about the intricacies of this and working with patients. But we need to make that diagnosis just like we would any other diagnosis. And then when we work with patients, utilize the science to have this more clear and simplified framework that can be put into practice to help them know what to do. So this is kind of an outline that's based primarily on the work of Dr. Howard Schubiner, who's put a lot of thought into how to systematize working with patients and understanding the diagnosis when we're talking about this entity, which has a lot of different names now: primary, neuroplastic pain, centralized pain, neural circuit pain. And actually I always kind of learned this distinction of like, is it primary neuroplastic centralized pain, or is it not, like quote unquote structural pain, is in some ways a little bit of an artificial distinction in and of itself, because there's always a neuroplastic element, right? The experimental data supports this, but it's just a matter of kind of how much there is, and is it everything that's driving it, or is it a large part or a smaller part? And so these techniques can be applied to maybe potentially every permutation, but we're talking mostly about situations in which case, for example, there's been a diagnostic process to rule out other conditions, and they've arrived at typical diagnostic labels like, quintessential one is fibromyalgia. That is primarily one that's not correlated with actual tissue damage right here and right now. So there's a whole process of kind of going through this that you can work with patients on that don't have time to really get into detail, going through sort of a systematic approach of kind of additional diagnostic criteria and kind of testing in the office that can give patients more of a firsthand understanding of what's going on in their bodies. One thing I'll mention at the bottom, we'll maybe mention at the end if we have time, is how does it integrate with other things that we do already for pain that can be quite effective. And one of the things that I have done a lot of and continue to do with patients is osteopathic manual therapy. And right now I treat a lot of people with the fascial distortion model, a type of approach to treatment where you're correcting these myofascial distortions, and it can have a really dramatic impact very quickly on patients' pain and function. What I've come to learn over time is actually response to those treatments, like a positive response in many cases, is actually further diagnostic evidence of neuroplasticity in the nervous system at work. And so integrating that too, I think, is a really other interesting area that I continue to explore. So like we talked about, part of this process is actually dispelling kind of incorrect information patients might have heard before. And that can be really, really important because like we talked about, the brain will predict what it expects will happen. And again, that prediction process is largely subconscious or unconscious or non-conscious, whatever word you prefer, but something that we're not fully aware of. And this is, I think, particularly true with neck and back pain. This is a really interesting study, systematic review of over 3,000 patients, published in 2015, that looked at how many people without neck and back pain have findings on an MRI. And if you look at this, things that are often remarked about, degenerative disc disease, disc herniation, etc., facet arthropathy, as we sort of often draw a linkage to pain for patients, actually very poorly correlate with pain, especially some of these like disc degeneration. By the time you're 40, I'm in my 40s, over 2/3 have significant disc degeneration, but you don't necessarily have to have any pain. An interesting study showed how powerful this is, what I call the nocebo effect, the opposite of the placebo effect, where we're not really physically doing something to a patient, but maybe inadvertently or mistakenly, it makes them worse. They took patients with at least 3 months of low back pain, put them into two groups. One, I said, here's your MyChart result. Read the MRI report of everything going on in your spine. And then the other group, they interpret it correctly to say, this shows only normal incidental age-related findings. Doesn't explain the cause for your pain. They followed them over just 6 weeks, and you can see what happened. Group A, where they read their report, worse pain, oops, wrong screen, worse pain, worse functional status, less self-efficacy, worse mental health. And the opposite, pretty dramatically, was true of the other group. This actually happens in other areas too. I think it's most important in back and neck pain. I can send this out later if you're interested. This was published a couple of years ago, but reviewed other areas of the body that we frequently image with MRI. And they found, just to highlight a few things, that a lot of people have all sorts of findings, but yet have no symptoms at all of pain. For example, 9 out of 10 athletes have rotator cuff tendinopathy. 9 out of 10 athletes have hip labral tears. Over half of people over 40, again, we're talking about, oh, now you're over 40, but will have knee osteoarthritis and yet have no pain. And so these are data, I think, that we really have to look at closely and ask those critical questions. What is causing pain in my patient? What's the main driver of it? There's this quote that Dr. Schubiner brought to my attention from a long time ago, but perhaps still relevant. And it says, for each illness that doctors cure, this is by Marcel Proust, each illness that doctors cure with medicine, they provoke 10 in healthy people by inoculating them with a virus that is 1,000 times more powerful than any microbe. The idea that one is ill. Just some food for thought as we practice the art of medicine. So, a lot of information here. Thanks for staying with me. Hopefully You're all with me here still. If we put it all together, how do we explain this to patients and use it to help them? Here's a diagram that I draw by hand for patients now all the time. Try to put it in a slide. Let's see what you think about it. But I draw at the middle what we've been talking about a lot, the idea of the predictive brain. That is how the brain is generating our moment-to-moment experience and regulating the physical body in pretty much every respect. This intricate, constant activity, mostly in the background that we don't know about, we're not aware of. One of the primary questions of the brain, like we were talking about before, is saliency, importance to the safety and survival of the organism, right? It's going to prioritize survival in the short term over pretty much everything else. That's what the brain is kind of evolved to do for us, is it has to figure out, are we safe or are we in danger? Are we safe or in danger at every given moment? And depending on that determination, it's going to generate a whole series of physical responses. We're really familiar with, I think, the autonomic nervous system probably being the most dramatic and immediate one or component of this, where right, the fight or flight or freeze responses, which we can all relate to, right, happens to us, all the time. And the brain, again, is using the information it has available to it. It's this processing network in your skull, and it's trying to use what it knows. So it uses past experiences, really important. It's understanding of the stresses that we're under right now. This is really crucial, so I give it its own little arrow. And then other contextual clues, interoceptive from within the body and exteroceptive from outside the body, sensory input. Again, like we were talking about, relatively selectively. The brain doesn't pay attention to all of this all the time. It's only picking and choosing what it thinks is relevant and needs to change its already in process and in practice predictions. So it's only some of those contextual clues. And like we were talking about, it's going to generate all these physical things. We've been focusing a lot on pain, but this actually relates to pretty much every condition that we've come to understand as functional in the human body. It creates muscle tension, right? Again, autonomic nervous system, neuroendocrine system, immune system. Digestive symptoms, IBS. Cardiovascular symptoms, postural orthostatic tachycardia syndrome, palpitations. Numbness, tingling, paresthesias, neurologic symptoms like brain fog and confusion, memory problems, anxiety, which is a bucket category for a lot of autonomic type symptoms, fatigue. Some would argue depression is actually primarily more of a physical diagnosis, right, with emotional component, and we can get into this if we had time. But I highly encourage you to check out Lisa Feldman Barrett's book, How Emotions Are Made, from which I've learned a ton of this. And her reframing of what emotions are actually is that emotions are actually our brain's readout and conceptual understanding of the state of the body, the physical state and health of the body, generated in a predictive fashion. It's a sort of a brainful there, but it actually, again, blurs this distinction between physical, emotional, etc. A really important part of this process, though, is that when people are experiencing, oops, sorry, I clicked the wrong thing. Physical symptoms that they don't understand or maybe have misattributed to, say, degenerative disc disease when that wasn't what was causing their pain. Whatever, that simple lack of understanding of this black box of what's going on, and or that fear, that maybe misbelief that our body is broken, is going to generate, understandably, I mean, for everybody in this situation, we would feel fearful, focus on a lot, worry about what that might mean for our safety. That is actually a crucial part of chronic pain for a lot of situations where that is actually part of this continued activation of the danger signal that then contributes to those stable predictions of the brain to result in pain. And so kind of broadly there, this is where we talk about any chronic symptom we think can be explained by this model where the brain has actually generated some response, maybe at some point in time in the past, that at its best estimation thought was protective and adaptive for the organism at that time. However, maybe circumstances has changed, but certain things maybe haven't, or they're similar enough to what happened before, perhaps with regard to stress, similarities to before, other clues, triggers, conditioned responses, and then it leads to perpetuation of that predictive cycle or that symptom generation, and it just doesn't go away because the brain hasn't changed what it initially started doing. How do we change this? This is the treatment part where our job, it all rests on this part. That part where we're talking about the brain can revise its predictions and change. It's neuroplastic. This is not permanent. All of this is not permanent. If we provide the right corrective input to the brain in a way that it is able to incorporate that and revise and change its predictions, that will lead to changes in the central process, which is the root cause of our physical symptoms. And the physical symptoms then will change. That's the pathway. So this is the central diagram I use all the time and come back to again and again with patients now. To summarize that, our job then is to treat chronic pain and potentially other symptoms, is to correct the brain's prediction error by providing accurate corrective input. We need to decrease the fear and the threat conditioning components by helping the brain feel safe when appropriate, and essentially calming this sort of overactive danger alarm kind of loop, right? We need to maximize neuroplasticity in the brain's openness to changing previous predictions, which to me is basically summed up in, what is mindfulness training? Mindful awareness. That is the process of, behind the scenes, maximizing neuroplasticity, right? That beginner's mind. So helping our patients do that and identify along the way what are the major drivers of continued prediction error, including specific stressors that we're talking about or other clues or ways that the brain keeps activating that danger pathway. Could be social, emotional, situational habits, personality tendencies like self-criticism, perfectionism, etc. Make changes to the situations where appropriate when we can, if we really need to. For example, if there's a really toxic situation that we must change, like someone's job, maybe that has to change the pain, because that's a big driver, if that's possible. And if we can't change the situation, how can we change at least the relationship that we have to those kind of triggers whenever we can? To say perhaps there isn't something that's actually physically dangerous, but it is something that we've developed sort of a danger relationship with. So this is all encapsulated. A lot of this is contained in something called pain reprocessing therapy, which is developed by Alan Gordon, Howard Schubiner, and other colleagues to kind of create a systematic approach to help patients go through this process. This is a very brief summary. Again, this can be a subject of entire other training courses. But in brief, this is kind of putting a lot of those part pieces together. We first have to provide the pain neuroscience education. Then we have to continue reinforcing the personalized evidence that this applies to your symptoms. We utilize a technique called somatic tracking, which I basically think about as guided mindful awareness. And initially it's guided, like a lot of mindfulness practices, right? It's initially this guided mindful awareness, but with an added sort of active ingredient of reappraising and correcting misinterpretations of sensations in the body, if they're there, using pain neuroscience to help the patient internalize and experience those sensations not as dangerous, but as basically harmless sensations when there isn't actually tissue damage present. We use other kind of CBT psychological techniques along the way. We use graded exposure to triggers and avoided activities to help the brain experience these corrective experiences where these things actually aren't dangerous. That's actually not what's causing your pain. And addressing, very importantly, any other emotional threats that might be present, potentially using whatever techniques might be appropriate. All of this delivered and cared for with compassion, which is very, very important. As Alan Gordon summarizes here, chronic pain isn't a pain problem, it's a fear problem. So shifting the focus from the pain itself to the drivers of the pain and focusing on changing those and allowing the pain to change as a result. We're running short on time. I'm sorry, I tried to put too much into this presentation, perhaps, but just to briefly talk about this, and I'll send along the reference for anybody who's interested, just published in 2022, a randomized controlled trial on pain reprocessing therapy, where they randomized, this is by Yoni Oshar, Alan Gordon, Howard Schubiner, Christy Lippi, and colleagues, and they randomized patients with at least 10 years of back pain to get various assessments, including functional MRI, and then go through either 4 weeks of pain reprocessing therapy, get a placebo saline saltwater back injection for their back pain, or just do their usual care. And they follow them up over time. This is actually very similar to our previous slide, but talks about the structure that they used in this study. What they found, I think really impressively, is that in the PRT group, so everybody got a little bit better, right? It happens a lot in trials, that there's benefit kind of just from being in the trial almost, but PRT got substantially better. And with just 4 weeks of treatment, that lasted for up to a year. That's how long they followed people. So at the end of the study, almost 2/3 were pain-free or nearly pain-free. And even a year later, about half of them still felt that way. We don't have to get into this in a lot of detail because we don't have time, but they did neuroimaging studies that basically match up with a lot of the things that we talked about to show there were changes in the brain in ways that match up with what we know plays a role in generating pain in people, which is really cool too. A really neat other layer of the study, I think. So the take-home points, again, can't spend a lot of time on it, is, I'll send out the reference if you're interested, is that this had really, really great results for the patients who were in the study. 2/3 of patients were pain-free or nearly pain-free, and taught us more about kind of how this might be happening behind the scenes in their brains and bodies and their psychological kind of belief systems, which are of course based on that. And it's really exciting. Just one study, of course, and maybe we need additional studies to further know how to adapt this best to other populations. But it's a great study, I think, that to inspire us, I think. So just to summarize, we talked about this just a few minutes ago, so I won't go over it again. This is the central guiding principles of the treatment. This is the diagram that I use to explain and help patients know where to look to find out for them what we can use to help them get better. That continues to be in development. Keep making improvements, hopefully. Other treatments really come into play with this too. Pain reprocessing therapy was one thing we talked about, but like we were saying, mindfulness is really at the core of so much of this, and something I always try to encourage patients and support them in incorporating into their treatment. Another treatment which we could spend a whole lecture on or more, a whole course on, I took a training course in this, is something called emotional awareness and expression therapy that was developed by Howard Schubiner and Mark Lumley to address what can be a very important component for patients to address the role that our relationship to our own emotional experience itself. If we treat emotions as dangerous, and we aren't able to process those in a healthy way, how that can actually be sort of an undercover initially driver of the danger signal and predictive processing to perpetuate danger in the downstream physical symptoms. It's really interesting. There's some high quality literature on this too, research trials that are demonstrating its effectiveness for chronic pain, which is really exciting. And then other therapies that I've been learning about and continuing to find ways to integrate in this framework, internal family systems, expressive writing and arts and movement, mindful self-compassion. We were talking about how compassion and self-compassion is really at the core of so much of this work. Other somatic mind-body therapies, and just the basics of what Dr. Feldman Barrett calls balancing the body budget. What are the ways, additionally, that the brain is getting subconscious signals, again, through those interoceptive pathways that were not safe, that were in danger? And these core components are, I think, indispensable in the overall recovery process. And again, at the center is always mindfulness and awareness of this, how sleep, nutrition, movement, and social connection really are essential in helping our brain be healthy. Beyond that, yoga, a lot of people here probably know I'm a huge fan of yoga and therapeutic yoga, meditation, Tai Chi, Qigong, energy medicine, various other techniques that relate to that type of framework, guided imagery, acupuncture, particular approaches in CBT that can integrate with this. Of course, pain reprocessing therapy itself has a lot of CBT elements within it. And then I list here what I referred to earlier, manual therapies and physical therapy. I think if you're using a pain neuroscience framework, can be very beneficial, but they're most beneficial when we focus on the brain's role in this neural circuit, neuroplastic, neural pathway process of retraining, and not inadvertently perpetuating sort of the sometimes subconscious belief that our body is broken and needs fixing, and to keep the focus on the neuroscience. I have to wrap up here now, but like I alluded to, this goes way beyond pain potentially to anything that we consider primarily or largely sort of functional in medicine. I can send this along too if you're interested. A lot of additional resources to learn more about this, books, apps, podcasts, websites. I highly recommend these for further learning and training opportunities that I've had the opportunity to learn from myself. I can send these out too, courses and training and mentoring opportunities in the science and practice of this field of medicine. So I just want to end with gratitude again towards all of the teachers and people I've learned from in this process. I'm just so grateful for that, and of course, just being able to do this work is a tremendous honor. And thank you all for listening for this hour. And if you want to be in touch, my email is there. It's on our website, I think, too. And I really would be excited to work on this together going forward with anybody who is interested. Yeah, just let's be in touch and work together. That's all I have. So
thank you so much, Jonathan.
Change my view here.